Zoll LifeVest is a proud sponsor of CardioNerds. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, Cardio Nerds. My name is Anna Radakrishnan, and I'm a third-year internal medicine resident, incoming cardiology fellow at the Mount Sinai Hospital. I cannot be more excited to introduce this episode, focusing on heart failure with preserved ejection fraction, or HFpEF, in women, a topic that is both clinically significant and rapidly evolving. Women face a nearly double lifetime risk of developing HFpEF compared to heart failure with reduced ejection fraction, or HFrEF. Yet their unique risk factors, pathophysiology, and treatment responses are often underrecognized. In this episode, we'll take a deep dive into the biological underpinnings, diagnostic challenges, and emerging therapies for HFpEF in women, highlighting what we know, what we still need to learn, and how we can improve care for this patient population. Today, I'm joined by CardioNerds Academy Fellow Dr. Apoorva Gangavelli, internal medicine resident at Emory University, tremendous member of the CardioNerds team, and fellow member of Heis Eindhoven. Apoorva, great to be here with you today.
Thanks, Anna. Today, I have the great pleasure of introducing Dr. Martha Gulati. Dr. Gulati is a professor of cardiology at Cedars-Sinai Heart Institute and the director of prevention, the associate director of the Barbara Streisand Women's Heart Center, and the Anita Dan Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. She's the immediate past president of the American Society for Preventive Cardiology and the best-selling author of Saving Women's Hearts. Dr. Gulati, thank you for being here and welcome back to CardioNerds.
Thank you for having me.
We are in for a real treat, Cardio Nerds, as we have the pleasure of being joined by not one, but two absolute visionaries in the field. I'm thrilled to introduce Dr. Anu Lala. Dr. Lala is an associate professor of cardiology and population health at the Icahn School of Medicine at Mount Sinai, director of heart failure research, data coordinating center leadership for the National Heart, Lung, and Blood Institute Cardiothoracic Surgery Network, program director for the Advanced Heart Failure and Transplant Fellowship at Mount Sinai, and co-editor of the Journal of Cardiac Failure. Dr. Lala is a leader, teacher, clinician, and a personal mentor of mine. Dr. Lala, welcome back to Cardio Nerds. I can't think of two better people to be joining us today.
It's so kind of you, Anna. I'm so excited to be here.
To start us off, we would like to discuss a case from our CardioNerds Integrated Heart Failure Prevention Clinic. Dia Stali, a 62-year-old woman with a history of hypertension, obesity, type 2 diabetes, and AFib, presents to the clinic with progressive dyspnea on exertion over the past 6 months. She finds it difficult to climb stairs and experiences fatigue even with daily activities like grocery shopping. She has occasional lower extremity edema, but denies orthopnea or PND. On exam, her BMI is 34, her blood pressure is 138/84, heart rate is 76. She has no significant JVD, but has mild pedal edema. Auscultation reveals an S4 gallop, but no murmurs. Labs show an NT-proBNP that's mildly elevated at 560. Her echo shows an EF of 60%, left atrial enlargement, and mild diastolic dysfunction. Stress testing is negative for inducible ischemia. Dr. Lala, does Ms. Stali's presentation raise suspicion for HFpEF? And what specific aspects of her case make you consider this diagnosis?
Yeah, thanks so much, Apoorva. I think this is such a classic presentation that we see, right? So Ms. Stali is over the age of 60. Not that that's necessarily considered to be elder, but if you look at that H2FpEF score, elderly is classified as age over 60. She has some evidence of increased filling pressures, I would say, with the elevated NT-proBNP, the fact that she has left atrial enlargement. We didn't specifically hear on whether she had an E to E prime ratio over 9, but one can deduce that she likely has some element of elevated filling pressures. We also don't know if she has any pulmonary hypertension based on that, or is there a history of atrial fibrillation mentioned, but she is what we would classify as quote unquote heavy, right? Her BMI is over 30. And one thing that doesn't go into this score, of course, is the influence of hormonal imbalance, right? So she's likely to be postmenopausal, which increases her risk of having HFpEF as well. And so there's a number of things in this case that make me want to pursue diagnostics to see whether she indeed does have the heart failure syndrome. I want to make the point here really quick to emphasize the fact that heart failure is a clinical syndrome. And so above all these scores and these classifications and criteria, the first thing that should really, really be at top of mind is the fact that she finds it difficult to climb stairs and feels fatigued with daily activities. That to me is the biggest red flag, if you will, because that fits the syndrome of heart failure. And then when you put all of the other things together, it's highly likely that she does indeed have HFpEF.
We often hear that women present differently with HFpEF compared to men. How does Ms. Dolly's case reflect these differences? And are there any common misdiagnoses or pitfalls in recognizing HFpEF in women?
Yeah, thanks for bringing this up. And it's, first of all, I love this integrated prevention heart failure clinic. I think we need to see more of these across the country and globe. And, Dr. Gulati has influenced me in this space so profoundly. When it comes to women, we sort of just touched on this earlier with the fact that we know that estrogen deficiency can have an influence on natriuretic peptides. And so natriuretic peptides are relatively deficient. There's this interplay between lack of estrogen and lower natriuretic peptide levels. And so that sometimes can lead to misdiagnoses. I would also say that it tends to be common, and I think Dr. Gulati could speak to this better than I, but women themselves actually don't think much of their symptoms. They think, oh, I'm overweight. In this case, her BMI is over 30. She says, oh, I'm overweight. I can't really do much. I'm getting older. I'm probably out of shape. And that's why I'm dyspneic. And so they oftentimes don't pay attention to those symptoms. And it's really up to us as clinicians to take really good histories to see what indeed actually makes them feel limited. Martha, what would you add?
That's a really good point. I will say that one of the symptoms that women experience more than men seems to be this dyspnea on exertion or exercise intolerance. But the problem, as Dr. Lala said, is correct, that it's not just the patient who says, well, I've gained weight, and we always make our patients step on the scale before every clinic visit, so we sort of reinforce that. But I also think it's physicians. I do think that we undermine women's symptoms, and often we do have some bias with people with excess weight. We will attribute every problem to the excess weight rather than attributing it to what potentially could be the underlying cause. And that's more seen in women than in men. I think also other things, the lower extremity edema that we heard about in this patient as well, again, more likely seen in women than in men. So these are the things that we're looking for, but I think we make the diagnosis of HFpEF too late. It takes a long time between a patient presenting and actually getting that diagnosis.
Thank you for raising those really important points. Dr. Gulati, Ms. Dolly's case exemplifies the complex interplay of cardiometabolic factors that predispose individuals, especially women, to HFpEF. Can you walk us through the metabolic milieu that culminates in HFpEF? Specifically, how do conditions like insulin resistance, visceral adiposity, and systemic inflammation contribute to the myocardial and vascular dysfunction that we see in women with HFpEF?
Yeah, absolutely. I think, of course, we've already touched a little bit on excess weight or obesity, certainly being strongly associated with HFpEF. And we know obesity and the interplay with the cardiometabolic and kidney risk, all of that has increased recognition. I think one thing that is important for everybody to take away, though, is you can have obesity and no other cardiac risk factor, and that increases the risk for heart disease, including heart failure and specifically HFpEF. So, looking for the other risk factors, they may or may not be present, but we have to start thinking of obesity both as its own independent disease, but also as a risk factor for cardiovascular disease, including HFpEF. HFpEF, particularly more so than HFrEF, has this strong association between the two. And so we should actually be more proactive when we see somebody with excess weight, thinking about could their symptoms actually be due to things like HFpEF, because it is very possible that that's already happening. And I think the other thing that we know is not just the relationship with excess weight, but also where the excess weight goes or the type of fat that is deposited and where it's deposited. And specifically, we worry about visceral adipose tissue, that it's associated with dyslipidemia, hyperinsulinemia, as well as cardiovascular disease. I know not routinely does everybody check for visceral adipose tissue. This may become more common for us to do in time, but I think right now you might get this information by, other studies that patients have had, not necessarily cardiac imaging, but maybe they've had an MRI or a CT for another reason, and maybe somebody has commented already on visceral adipose tissue. But that is the risk factor or the risk of obesity when we have more visceral adipose tissue that we should have heightened concern again for HFpEF and that association with the whole cardiometabolic risk. We certainly know inflammation as well is along that pathway. And again, we see that inflammation is much more common in HFpEF, but also much more common in women just at baseline. So that issue with the inflammatory pathways being active and immune dysregulation and having metabolic dysfunction all go hand in hand. And specifically, and I know we're probably going to get into this, but the relationship of certain disease processes like microvascular dysfunction, which is so closely linked to both inflammation as well as HFpEF. So again, some unique risk factors for women specifically related to inflammation. Additionally, diabetes or insulin resistance, we have a stronger association with cardiovascular issues in patients who have diabetes. And that's true for type 1 and type 2 diabetes, but also people with insulin resistance. And so all of these things, all these risk factors I'm talking about, they're so linked to that whole cardiometabolic milieu. Hypertension as well, huge risk factor for HFpEF, specifically in women. And again, part of the risks that we should be looking and not just thinking about obstructive coronary disease or coronary artery disease, but thinking about HFpEF more. That has to become more front and center when we're seeing people at risk.
Martha, I think you hit on everything as usual. I really like the way you broke that down, right? It's basically visceral adiposity, which is not just about excess fat, but really dysfunctional adipocytes, right? And you already touched on that nicely. We talked about systemic inflammation, which is this sort of silent driver leading to endothelial dysfunction, reduced nitric oxide bioavailability, and then this insulin resistance. This to me is so interesting because really promotes lipotoxicity and it leads to fibrosis, stiffness. And I like this idea of cardiomyocytes being less efficient. They're more susceptible to stress and therefore more prone to fibrosis. And when you think about the sex-specific susceptibility, we know, as you mentioned, a higher prevalence of obesity and metabolic syndrome, particularly in the patients who are postmenopausal or women who are postmenopausal. There's a greater sensitivity to inflammation and sort of hypertrophic signaling by way of hypertension and other mechanisms, as you mentioned, more microvascular dysfunction, diffuse fibrosis, and then it kind of leads to less endothelial resilience, if you will. And I think that sort of exacerbates the entire metabolic inflammatory cascade.
Thank you, Dr. Lala. I know we touched on a little bit of this, but we know that certain risk factors are either sex-specific or more prevalent in females and may contribute to the development of cardiovascular disease, such as HFpEF. Factors such as pregnancy-related complications, such as hypertensive disorders of pregnancy, menopause, autoimmune diseases, have been implicated in cardiovascular risk. Are there under-recognized or less commonly discussed risk factors that we should be assessing in patients, like Ms. Dolly, that may have predisposed her to HFpEF? And how do these factors contribute to HFpEF risk?
Thanks, Apoorva. I think that's such a great question. I think that's exactly the kind of clinical curiosity we need to kind of sharpen our approach to diagnosing and managing HFpEF, especially in patients like Ms. Dolly, who may not, I would say, fit the classic stereotypes of heart failure, but carry substantial risk. I think, as Dr. Gulati already mentioned, beyond the well-recognized contributors like hypertension, diabetes, insulin resistance, obesity, older age, there's also these under-recognized factors that you're alluding to. So if you try to unpack these, I'd say one that's often under-recognized, but a big contributor is sleep disordered breathing, like obstructive sleep apnea. This is often under-recognized in women because they have atypical symptoms. So they might just have more kind of generalized fatigue as opposed to daytime sleepiness. And we know that OSA causes intermittent hypoxia, and that leads to like sympathetic overdrive, nocturnal hypertension, all of which can contribute to cardiac remodeling and diastolic dysfunction, and also potentially increase pulmonary pressures. The other thing, since this is like a prevention heart failure clinic, we don't talk about physical activity enough. So it's not just a lifestyle issue, but physical inactivity contributes to sarcopenia, right? We kind of, as Dr. Gulati alluded to, we make this like very oversimplified relationship between obesity and exercise. And we have a lot of kind of judgment around this. And we say, oh, this patient has a sedentary lifestyle and that's why they're overweight, et cetera. But it's not just that, right? It's what are the metabolic repercussions of not being active? So we talked about sarcopenia, but there's also like chronotropic incompetence. There's reduced skeletal muscle oxygen extraction. And these amplify the symptoms that are most classic, like dyspnea. Women in particular, I would say, end up in this like deconditioning loop. And so oftentimes it's really important for us to emphasize the importance of exercise, not just to lose weight, but rather to make sure some of these other deleterious effects don't take place. Along those lines, frailty and sarcopenia can be present even in patients or individuals who are overweight. And that contributes to less physiologic reserve, autonomic imbalance, and more inflammation. Just to recap really quick, we've touched on frailty, inactivity, obstructive sleep apnea. And then the fourth, I would say, is it's a little bit controversial, but I think it's interesting to think about, which is iron deficiency with or without anemia. And what we've seen from all the trials is that iron repletion in those patients who are iron deficient does contribute to better function. And I think that's what we can say at this point. But it's important for us to kind of query that in our patients. And then last but not least, I'd say chronic kidney disease. This is why I love the popularization of cardio-kidney metabolic health, because we're moving from siloed systems of care to more whole body systems of care. And so we have to take into account all of these other comorbid conditions. So we're treating our patients holistically. So CKD contributes to fluid dysregulation as well. It also contributes to vascular stiffness and inflammation. And so we often see it running in parallel with insulin resistance and hypertension, but we don't necessarily pay as much attention to it. And now we have newer medications like the nonsteroidal mineralocorticoid receptor antagonists, for example, that also improve kidney function. And that's probably why we're also seeing beneficial effects in heart failure with preserved ejection fraction.
That is an awesome segue to our next question, actually. So, Dr. Gulati, looking back, if we had seen Miss Dolly 20 years ago, what preventive strategies might have helped delay or prevent the onset of HFpEF in her case? And more broadly, are there specific lifestyle modifications or pharmacologic interventions that are particularly effective for women at different life stages?
Well, that's a great question. We can't necessarily go back 20 years ago. And I would say probably 20 years ago, more likely this diagnosis would be missed. But from a preventative standpoint, if we were seeing someone, hopefully we would intervene early on some of these risk factors. Certainly weight loss is not an easy issue. And depending on when she started gaining weight and what part of life. I mean, we certainly know that for women in the perimenopausal to menopausal ages is where we do see increases in weight higher than other times in life. So just depending on what she was at the time that she's seeking out preventative care and what risk factors she has, hopefully we could be more proactive. And I mean, ultimately, this is why Anu and I were working on this specific topic, because it's one thing to diagnose people and then we're dealing with the consequences of the disease. It's probably a better thing up front to identify somebody at risk and help them modify traditional risk factors that we know how to treat, and try to prevent the disease. And so it's always hard to go back in time because I don't know when her risk factors appeared. But hopefully, if we were meeting this patient as things started appearing, that we countered them. And I think that's probably the hardest thing for women. Often even the traditional risk factors that everyone knows well don't get often routinely addressed in women in the same way that they do for men. Meaning that if you go for preventative care, for women, we're often thinking about bikini medicine. We're thinking about breast and reproductive system, and we don't really focus even on simple things like blood pressure. I know her blood pressure was high on this particular case visit, but how long has it been high? And is that something that we could have intervened on a lot earlier? When did she start gaining weight? And could we have advised her at different points to do something differently? Certainly, of course, we're living in a modern era of being able to better treat obesity or excess weight. But of course, 20 years ago, we wouldn't have had the tools that we have now. And so certainly, I think weight loss has been a challenge for all our patients. And it's also been a challenge for physicians who want to help their patients get to goal. But telling people to move more and eat less is always one part of it, but is not the only solution and oversimplifies why people gain weight. I think Anu already really touched upon this point about the sex-specific risk factors, and I think that is something that certainly 20 years ago, we weren't routinely asking women and identifying them at higher risk, and often isn't part of the history even today. So even 20 years have gone by, we've been identifying these sex-specific risk factors. Again, the majority of them tend to occur during the reproductive years that we know of. But again, to me, that points to somebody at higher risk for many forms of cardiovascular disease. And I mean, this woman also has, we haven't really touched on it, but has atrial fibrillation in addition to likely having HFpEF. And again, if we could have been more proactive at identifying any of these risk factors and treating them more aggressively, especially years ago, that's really all we could do for these patients because we didn't really have some of the more modern medications that we have that can treat people once they have disease. But I'd rather identify people at risk and prevent them from getting disease. And that's why I'm a preventive cardiologist.
Now I feel like being a preventative cardiologist. But Martha, you've taught me to look at this with the lens of my heart failure experience. And I love that. So really my mode of thinking has changed to what you just mentioned, really, which is the fact that we need to be so proactive about managing risk factors rather than managing disease. I think a lot of you know how much I harp on the fact that words matter. And I really love talking about health as opposed to disease. And so like preserving your cardio, kidney, metabolic health and optimizing it is really like the way we all need to be thinking. And I would say, even though patients have a diagnosis of HFpEF, it doesn't mean we can't still think about prevention, right? That's just secondary prevention, really. In fact, I would go so far as to say that post-transplant and post-LVAD, most of what we're managing is actually risk factors like hypertension and obesity and insulin resistance, et cetera. So that's like tertiary prevention, if you will. So I think prevention is not just something that's at one end of the spectrum, but rather is applicable across an individual's lifespan. And I'm sure we're going to talk about this, but a lot of the medications that we're now using to treat HFpEF are really applicable in the prevention world as much as they are in the treatment world after a diagnosis of HFpEF, for example. So just to recap, I would say just because you have the diagnosis doesn't mean that you should ignore the management of risk factors for the diagnosis because it's already established. In fact, it becomes more important, I would say, to really make sure that hypertension is controlled, that weight is adequately managed, that physical activity is promoted, that patients are getting enough sleep, that their lipids are being addressed. I think all of these things come into play even more profoundly once the diagnosis of HFpEF has been made.
I think that's such a good point, Anu. I think that the intersection between prevention is now reaching out to all the specialties, and especially for a disease state like HFpEF. I mean, one of the major things that occur to the patients who suffer from this is repeat hospitalizations. And if we did better once we make the diagnosis of HFpEF at managing all the specific cardiovascular risk and empowering the patient to understand what might make them more symptomatic or make them feel worse, and how we can obviously how we can try to improve that. I think that that could change the trajectory now, also hand in hand with new medications that can also potentially keep our patients out of the hospital. But it always will start with managing the risk factors that exist.
Now looking into the evolution of HFpEF management, where were we 10 years ago? What insights did trials like TopCat give us about treating this condition, particularly in women? And how has this shaped our current understanding? I'll turn to you first, Dr. Lala.
Ooh, I love this question because we have come so far. And I think it's super exciting to look back and to see where we are today. So if we go back to 2013, 2014, we were literally just starting to acknowledge the fact that HFpEF is not just diastolic heart failure, right? And if you look at ICD-10 codes, that's still how we code things, right? Chronic systolic heart failure, diastolic heart failure, acute diastolic heart failure. But we started to understand, just kind of scratch the surface, was the fact that HFpEF is like a multi-system syndrome and that women were and still are disproportionately affected. So we just started to understand that. Then came the TopCat trial in 2014, right, which investigated spironolactone in patients with HFpEF. Their ejection fraction was 45 or greater. And the primary endpoint was CV death, cardiac arrest, heart failure hospitalization. And overall, there was no statistical benefit. But, and this has been talked about for forever, there were regional differences that mattered, right? So patients in the Americas versus Russia and Georgia, for example, there was some discrepancies as to whether the diagnoses of HFpEF were real across the board and by geographic region. And rather, when you looked at the Americas separately, there was a statistically significant reduction in heart failure hospitalizations. So what did TopCat teach us? HFpEF is heterogeneous, so that one-size-fits-all approach doesn't work. Women may benefit more from mineralocorticoid receptor antagonists than men. So this was a subgroup analysis. And, the outcomes in HFpEF are also driven by non-cardiac factors. And this, to me, is where we, again, have started to understand things more holistically and from a full body perspective, as opposed to just being cardiocentric. Like hospitalizations are often due to volume overload and comorbidities rather than just, arrhythmias or ischemia, for example.
Just to point out that TopCat did enroll 50% women in this HFpEF trial, which, we all know in cardiovascular trials, it's pretty rare for us to have half men and half women. So this was, to me, also just an important trial from that perspective, that it applies to the women that we see. And the signal, at least, that we saw with a better effect potentially in women was quite interesting.
Oh, completely. And thank you for highlighting that fact. It was one of the highest enrolling trials with respect to women. So it's certainly nice to see that. And also just, again, another marker of recognizing that HFpEF does affect women disproportionately compared to men. When we see where we've come in the past 10 years, things have evolved so much, right? So we're recognizing that there's metabolic dysfunction at the basis. I think of HFpEF as the sort of cardiac manifestation of metabolic syndrome, just the way you would see like MASLD, for example, as the liver's manifestation of metabolic syndrome. And so now we have, my goodness, so we've got SGLT2 inhibitors. They're class 1 guideline recommended for patients who have HFpEF. And the benefit is seen across the ejection fraction spectrum, including women, and they reduce heart failure hospitalizations, improve quality of life, possibly reduce inflammation. Combined endpoints in those trials with CV mortality and heart failure hospitalizations, but the benefit primarily driven by a reduction in hospitalizations. Then we've got the MRAs, and we already talked about more benefits seen in women, but particularly those with central obesity, metabolic syndrome, in congestion-prone patients, let's say, or elevated natriuretic peptides. the GLP-1 receptor agonists, right? So these are the like talk of the town in 2025. It's sort of like a new frontier. And I would say this has really, really changed a lot of our thinking because it's a clear recognition of how heart failure with preserved ejection fraction is a metabolic syndrome, sort of manifestation that requires that management. And I think Martha already talked about this, but we have to treat obesity separately and think of it as its own disease entity. And in doing so, we also are treating HFpEF. The STEP HFpEF programs showed a significant improvement in KCCQ, weight loss, 6-minute walk distance improvement, and that was with semaglutide, of course. And then more recently, we had the SUMMIT trial, which was a cardiovascular outcomes trial. It was 700 some odd patients with HFpEF and obesity, and it reduced the risk of cardiovascular death or worsening heart failure events by 38% compared to placebo. It improved KCCQ by 7 points, and this was also what we saw in STEP HFpEF. So it was interesting to see that consistency with respect to improvement in quality of life. It improved exercise capacity, so 18 meters were improved on the 6-minute walk distance. Of course, it allowed for weight loss, 12% versus 2% in the placebo arm. It reduced inflammation, and this to me is really interesting too. Like I wasn't checking CRPs routinely in my patients with HFpEF previously, and now I'm doing it more so. I can't say that I'm doing it with the targeted intention of reducing the CRP, but I think it's very interesting to note elevated markers of inflammation like CRP and then how they come down with these GLP-1 receptor agonists. And then there's also reduction in LV mass and paracardiac adipose tissue, which is interesting, right? In this obese phenotype of HFpEF, there's some sort of intrinsic cardiac compression because of pericardial fat. There's RV dysfunction as well. And so I think it's just so fascinating to see how we've evolved in that space. And then if I had to treat Miss Dolly today, I would probably think about, and we didn't hear enough about her insulin resistance or glucose, et cetera, but she has HFpEF. So I would start her on an SGLT2 inhibitor, regardless of whether she had diabetes or not. I would start her on a GLP-1 receptor agonist, in fact, and we can't say whether that should be semaglutide or tirzepatide. And then I would also potentially consider spironolactone, or one could say a non-steroidal like finerenone. And you already mentioned she has a high BNP, so that would be fitting. I'd refer her to cardiac rehab, not just for weight loss, but again, like we talked about before, for conditioning to improve sarcopenia, to allow for better vascular compliance, for better chronotropic competence. I'd screen and I'd treat her for comorbid conditions like we just talked about. And then, it's so much about communication with the patient, right? Especially around weight, like Martha already talked about. We have to be sensitive and also point to the fact that it's not just about losing weight or being overweight or obese, but it's about getting patients to their healthiest point. And that oftentimes is when they lose weight, but it's not because we're only looking to have them lose weight, if that makes sense. So I think we have come so far in 10 years, and I am excited, quite frankly, to see how we continue to progress in these fields.
Anu, I just wanted to add about the cardiac rehabilitation part. So we know that in the 2022 AHA-ACC HFSA guideline for heart failure, they gave a class 1 recommendation for exercise training in patients with heart failure, and they didn't specify whether it was HFpEF or HFrEF. So my assumption is it's a class 1 recommendation for all. But the problem with referring these patients to cardiac rehab relates to insurance coverage. Both Medicare and other insurers are not covering cardiac rehab for these patients. And so generally, as somebody who runs a cardiac rehab, we don't even accept them because we're worried about them getting a bill. And so this has actually been a barrier to them. There's now more and more research coming out just showing that early implementation with cardiac rehab actually improves not just their functional status, not just their frailty status, but also quality of life and depression. And I just got back, as I think I told you all last night, from the European Association of Preventive Cardiology, and saw the late breaker there was actually about cardiac rehab in patients with HFpEF, a really elegant study where they actually took just a small number. It wasn't a huge study, but small number of patients, put them into either exercise training with moderate resistance training, then exercise training with high intensity resistance training, compared that to other people that they just said, hey, go chew it and exercise. And these were all HFpEF patients. And they were able to demonstrate an improvement in functional capacity and quality of life, as well as chronotropic response, because to get into the study, you actually had to have chronotropic incompetence. So it was just a nice proof of concept, but we really are waiting for the outcome trials so that we can actually go to insurers and to the Medicare to make sure this gets covered. Because right now, you can say you want that, and you can certainly encourage patients to get a trainer to do these things, but it's very hard to get them actually to cardiac rehabilitation, which provides education, provides camaraderie, creates accountability for patients, and I'm the biggest fan of cardiac rehabilitation and wish that HFpEF actually could come to our cardiac rehab.
There have clearly been so many exciting developments in the field, with even more on the horizon as we've been seeing. So as you reflect on your own practice and your own patients, what personally excites you both most about the recent advances in our understanding and management of HFpEF? Dr. Gulati, let's start with you.
Gosh, there's so many exciting things. I think Anu already touched on the fact that years ago we had really nothing but diuretics to offer these patients. Now we've come to a place where we actually have medical therapy, proven medical therapy that can change outcomes. So we've come a long way. We have a greater distance to go, but I do think that it's a better time for our patients than it ever was before for those with HFpEF. I think the other thing is this, given what I do most days in my hospital, I spend a lot of time with women who actually have coronary microvascular dysfunction. And we've been spending the last, I don't know how many years, more than 20 years, actually trying to find out what this relationship between heart failure and microvascular dysfunction is. And we started out with data just showing that heart failure hospitalizations that happen in people, particularly women with ANOCA, that was one of the commonest things that was occurring to these women. And then now we have more data showing the association of the type of heart failure, particularly HFpEF, is such a common relationship with coronary microvascular disease. And it's something like 75% of patients who have HFpEF actually have evidence of microvascular dysfunction. So we haven't yet answered fully how to treat people with microvascular dysfunction, but we could be taking lessons from what we're learning now in the HFpEF trials to see if some of these medications would actually be beneficial for our microvascular dysfunction patients, just given the overlap and the greater understanding we have of the commonalities between the two.
All of those advances sound promising. Given the complex nature of HFpEF care, how do we break silos in care so that it's not just heart failure or prevention for these complex patients? Dr. Lala, how do you collaborate with providers outside of your subspecialty to take care of these patients?
Oof, that's the challenge, right, Apoorva? That's so critical. Just to reiterate the point, HFpEF is not just a heart failure problem, right? It's a metabolic disease. It's a vascular disease. It's a renal disease. It's a geriatric syndrome. It's a behavioral health and social determinant challenge. And so no one provider can just manage that alone, right? And we shouldn't really try to. This is going to be the key as we move forward. I think we're going to see more and more cardiometabolic clinics, cardiorenal rounds, cardio-OB alliances and connections for patients and women with early menopause, for example, or PCOS or pregnancy-related complications. And Martha's done so much in this space. And these are patients who are at early risk for HFpEF phenotypes as well. To answer your specific question, I think we have to leverage allied health professionals in primary care. So we have to have really multidisciplinary clinics with nursing specialists, pharmacists, dietitians, primary care physicians. I think what I used to do, if I could be vulnerable and share, is I used to ask my patients to fit into cardiology, right? And I would have this, oh, this is my specialty. This is what I can cover. That's not my wheelhouse. But now I'm seeing my role as a cardiovascular clinician to meet patients where they are. And that's oftentimes in the context of diabetes or CKD or OSA, or honestly, loneliness and depression. And I think I really love the fact that if you look back 50 years ago or so, there was this whole, most physicians were not very specialized, right? It was about treating a patient holistically because everything is connected and we needed to advocate for good health, period. And then over time, we've all become so specialized, right? So Martha and I are not just cardiologists, but she's a prevention specialist and a women's health specialist within cardiology. I'm a heart failure specialist or heart function specialist. But in becoming this specialized, we lost the connection between systems. And so I'm kind of very excited about the fact that we now are recognizing that we're all responsible for the health of our patients. And that goes beyond just being a heart-specific issue or problem. With respect to multidisciplinary care and how to bridge those divides, it's challenging, right? It's not a quick solution. But I think the fact that we have now shared language that's evolving. So I think when we train our fellows and residents to think of heart failure beyond ejection fraction, but to think more holistically about this syndrome, I think that's really important. I think we're going to see, and so this is just along the lines of education and awareness. I think multidisciplinary grand rounds are going to be really important. We can't just have cardiologists talking to cardiologists, but I would encourage CardioNerds, for example, and I know you guys have done this, to let's do something with nephro madness, for example, because having this crosstalk is so critical across disciplines. I think we can leverage our electronic health system record tools to facilitate diagnoses so that nephrologists are also thinking about HFpEF, for example, and we're also thinking about CKD, whether that's through prompts and co-management, communication tools. And then as a final thought, HFpEF is not just a disease state that we're learning more about. This is like a call to action, I think, not just for, incretin-based therapies, but really for new models of care, right? It demands, for me at least, it has demanded of me tremendous humility and a lot of curiosity and a desire to collaborate more. And I just love that. Like Miss Stolly in this case is not coming to us just to fix her heart, right? She's asking us to be looking at her as a whole person, to treat her with collective expertise. And that's going to require talking to one another.
I just wanted to add to that. I think one thing that we do need to do, though, is change the new generation. And I know CardioNerds is probably the right place to be talking about this. I think that one thing that hasn't changed in many years is the training manual, COCAT. And there's nothing in COCATs really about prevention of any type of disease. And so it's not even required to be trained in prevention when you leave cardiology fellowship, which is a huge issue and an issue that the American Society for Preventive Cardiology is trying to address. But to be honest, it really comes down to the training. Everyone needs to have some amount of skill and understanding and appreciation for all the risk factors that ultimately underlie most forms of cardiovascular disease. And I think that if we can start also training cardiologists, general cardiologists, since we all do that before whatever we do to specialize I think it will actually benefit our patients. So I hope that there are changes thought of there as well, because it's been a long time coming and we keep shouting this out, but I feel like we're just shouting to our same crowd saying, where's the prevention? Why do people not understand that it's everyone's job?
Thank you both for those really interesting, insightful, and thought-provoking comments. I'm sad that this conversation needs to come to a close, but to end it here, to end with our age-old favorite CardioNerds question. To both you, Dr. Gulati and Dr. Lala, what makes your heart flutter about managing cardiovascular disease in women?
I think what makes my heart flutter is the excitement in prevention and the way that things are changing, the way that we're developing medications to prevent heart disease, prevent hospitalizations. And the other thing, I guess, if I could add also, in addition to the changing therapies, is just the fact that there's conversations about prevention outside of the preventive cardiology field, the fact that we're intersecting and working with so many different specialties, really making this a common conversation and a goal of everyone.
I love that, Martha. I want to just say ditto. First of all, I love this conversation in general, right? This is for women talking about where we've come in HFpEF in women and where we're headed. I also, and Martha has been a major influence to me in this regard, I also am super excited about the fact that prevention is becoming sexy, so to speak. As I age, as I see my family aging, I think we all, regardless of whether we're in healthcare or not, recognize the importance of prevention. And I would say what makes me most excited is the fact, and I've mentioned this already, so forgive me for repeating myself, is the fact that we're moving towards whole body, holistic care. And I think the word holistic, and some of you know I'm in the Integrative Medicine Fellowship, that also has a bad rap for many reasons, which are understandable. But from my perspective, what it means is to see patients as whole people. And I am really humbled by how much more there is for us to do as cardiovascular clinicians, particularly for women, quite frankly, who don't necessarily present in the same conventional ways that we're taught. And I really love approaching patients where they are rather than thinking of them needing to fit into my box of cardiovascular expertise. So the only other thing I'll add is my great desire to see how we can also touch upon patients' sense of emotional well-being and spiritual well-being. And I hope that as we move to more integrated ways of taking care of patients, that we'll also be able to address their emotional and spiritual needs when we take care of patients.
That brings us to the end of today's episode. A sincere thank you to Dr. Gulati and Dr. Lala for joining us and sharing their expertise on HFpEF in women. Your perspectives have provided valuable insights into an often overlooked aspect of cardiovascular care, and we're grateful for the thoughtful discussion. Thanks again for being here today.
Thank you for having us.
Thank you so much.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.